My name is Birgitte, and I'm a physiotherapist, and I've been working within stroke at the Aalborg University Hospital for more than 10 years now. And my PhD is based on some of the frustrations that we experienced in the clinical settings when we were in contact with patients with transient ischemic attack. Just before we start, I want to make sure that we're on the same page as to the definition of a transient ischemic attack, and it's when acutely neurological symptoms resolve within 24 hours, and that it is presumed to be on a vascular origin. So in other words, it can be referred to as a bypassing stroke. And in Denmark, we use this called time-based definition, where the key thing is the resolution of symptoms. In other countries, it is also important if there is an acute ischemic lesion on MRI, as can be seen here. And if there is this lesion on an MRI, then the diagnosis would be stroke. But here in Denmark, even though there might be signs of an acute infarction, then the TIA diagnosis is given if the resolution of symptoms has been there. And since the definition is based on this resolution of the neurological symptoms within 24 hours, we in the healthcare system assumed that these patients would be able to return to their everyday life without significant impairments. And this transient nature of the diagnosis also means that these patients are not offered rehabilitation or extended follow-up, or are in contact with brain injury coordinators as well, or as at the same level as stroke patients are. In other words, we presume that they can go home and live their life without that many difficulties. Patients are usually admitted to an acute stroke unit, and they are discharged from here within 1 to 1.5 days. Some might also be seen in outpatient clinic, but for many they are admitted like other stroke patients and then quickly discharged. And the extent of follow-up after they go home is very dependent on where they live. Many receive a telephone call from a stroke nurse within 1, maybe 2 weeks, and the focus for this contact is on secondary prevention. And this is really important because these patients are at risk of having a new stroke. So therefore, it's important to make sure that they take their medicine, that they have lowered their blood pressure and their cholesterol level, and so on. But in some regions, patients do not receive this follow-up and they are left on their own after discharge, except for that follow-up that might be provided by their general practitioner. But again, the main focus at this time is on reducing the risk of a new stroke, which is important. But then for 5 or 6 years ago, we had the opportunity to provide an extended follow-up to some of these patients after 6 weeks. And here an occupational therapist made a telephone call, and we could hear, or we learned at this point, that some of these patients were not able to return to their everyday life as we anticipated. And then we went in and looked at the literature, and here it was also reported that around 1/3 experience fatigue, depression, anxiety, or cognitive impairments, all symptoms that affected their way of living afterwards and their ability to return to work or other activities. But many of these studies have been limited by a relatively small sample size or a short follow-up period. And it also includes both these patients with TIA diagnosis, but also patients that we call minor stroke. And this challenged the conclusions for patients with TIA, since one might think that some of the problems identified in these studies then would be for the minor stroke patients. And the follow-up, as I mentioned previously, is a lot different for stroke patients as it is for these TIA patients. An example of one of these patients is a lady I met a couple of months after her TIA diagnosis. She was in the beginning of her 60s and working a job that required quick decisions, a lot of multitasking, and being able to make these decisions at a really high speed. And she struggled to do that after her TIA. Things that she usually could remember and handle in her head, she had to write down, and it ended up that her whole office was covered by Post-its to making these connections that she could do simply in her mind before. But what really hit her was when she overheard her grandson telling his mom, why is grandma not funny anymore? And why doesn't she bake anymore? Then it hit her that it was not only at work she couldn't perform, but it was also in her family relations. Another patient, which I talked to recently, also explained how this diagnosis impacted the entire family. His daughter came home while the ambulance was there taking the father into hospital. And then one day, several weeks after discharge, he discovered that this young girl was standing and holding her hand over the father's name at their mailbox outside their house. And he asked why she was doing that, and she replied that she wanted to see what it looked like if this happened again, and he, being the father, did not come home. So it impacts, even though we say it's a transient ischemic attack, it impacts. And yet we have no evidence-based or patient-centered intervention to provide these patients, and we lack answers to what the focus should be in these interventions and who are in the need of it. And it becomes complex since some of these patients are able to return to their everyday life and go about it as they usually do, and others struggle. So we need to make sure that we're not putting negative impacts on patients who are not experiencing them, and same time focus also from an economical perspective on the ones in need. And this led to the following research questions for my PhD. What symptoms do these patients experience, and what is the time course? How does it impact their lives? Who are they? Who should we concern our focus on? And how can we help them? And this has led to 4 studies. The first study is a register-based cohort study where we investigated the use of sick leave benefits and home care to see what kind of impact it has on everyday life. Then we did a prospective cohort study to investigate what symptoms they experience and when they arise. And in this study, there was also embedded a qualitative study trying to get a more in-depth knowledge about the impact in everyday life, and also what facilitates and what barriers there are for their return to everyday life. And finally, a co-creation process to determine which interventions we should provide in the future. So the first study, we advise patients to have a sick leave before they go to work, and we advise them to be at home for maybe 1 or 2 weeks and then gradually start working again. So the research question was, how many receive sick leave benefits 5 to 12 weeks after the event? And we put the lower limit on 5 weeks because after that time, we would assume in the clinical setting that they were back. We used a lot of different national registries, but the most important was the Danish Stroke Registry and also the DREAM Registry, where all public benefits are registered. And when looking at the results, we identified more than 31,000 events. And after excluding patients who died within the first 19 days and the ones with severe mental illness, we ended up with a little more than 29,000 events that were included. Within these, there were 6,770 who were working before their TIA events and thereby included in the analysis of sick leave benefits. And we could determine that based on their payment of labor market contributions. And of these, 1,240, corresponding to a little over 18%, received sick leave benefits within 5 to 12 weeks after. So despite this transient event, almost 1 out of 5 received sick leave benefits 5 to 12 weeks after. Then going on to the cohort study, we included patients who were diagnosed with TIA from Aalborg University Hospital. We verified the diagnosis by 2 independent stroke neurologists to make sure that this was the diagnosis before they were included. And we recruited 354 patients in a time period of 13 months. And of these, 287 responded to the questionnaires and therefore included in the analysis. Interestingly, many of the ones who didn't respond, one of their reasons were that they were too fatigued to be able to participate, which is kind it's quite interesting that fatigue being one of the symptoms they report. We measured on fatigue and depression, anxiety, and quality of life. And we did this at baseline, which was within 14 days after their discharge, and then at 3, 6, and 12 months. The outcome that I'm going to focus on today is fatigue, because that was one of the things they really expressed when we talked to patients. We measured fatigue on 2 different fatigue scales, the multidimensional fatigue inventory and the fatigue severity scale. The multidimensional fatigue inventory covers 5 domains of fatigue: general fatigue and physical fatigue, reduced activity and reduced motivation, and mental fatigue. And the fatigue severity scale is more an overall fatigue level. When we look at one of the domains, general fatigue, we could see that looking at the patient group as a whole, the fatigue level did not vary much over time. It remained kind of at the same level at the 4 follow-up time points. This is the median of the fatigue level, and the range also seemed quite similar at the different time points. The cutoff score for this scale to say that it's pathological fatigue is 12. And when we used this cutoff score, we could see that more than 60% at baseline reported fatigue levels that high that we would call it pathological fatigue. And at 12 months, it was still more than half. When comparing to stroke, a new systematic review states that fatigue is present in almost half of stroke patients. And when we look at the specific outcome measures that we also used, it's a little over half that report fatigue using the multidimensional fatigue inventory. So it seems like it's at a similar level that TIA patients report this fatigue. And we could see that it was the same pattern identified on all other fatigue outcomes following TIA. So the next big question was, who are they? Because we know some report it and some doesn't. And to try to answer this question, we used linear regression and trying to test 2 models. The first model, we investigated whether some of the factors identified in the literature was associated to the experience of fatigue at 12 months. So we included information on sex, age, and acute ischemic lesion on the MRI. And this later part with the acute ischemic lesion was the one thing that in some countries determine if you have the TIA diagnosis or you are diagnosed with a minor stroke. When looking at the results, we got these visualizations. The red dots are the actual measured value at these 3, 6, and 12 months. And the blue dots are the model's ability to find the measured values. And we can see here that the model is not that good at explaining the variability in reported data. Then we had our model 2, where we added information on baseline level of fatigue. So we also put information in the model as to what the report fatigue levels are shortly after discharge. And here we can see that the model's performance increased significantly. It was much more able to explain the variability in the data and thereby say who might be at risk of fatigue at 12 months. And this is also visual with the likelihood ratio test, which is with this high number and also at a significant level, illustrating that our model 2 performs a lot better than the model 1. So to summarize, patients with TIA report fatigue levels comparable to that of stroke. And if they report fatigue already shortly after discharge, we need to pay extra attention. It doesn't matter that much what kind of gender they have or their age, or if there's acute infarction on MRI. But if they already shortly after discharge start to express this increased fatigue levels, we need to be aware. Then we wanted to explore how this impacted everyday life and go further into understanding some of these patients who report lasting challenges. What do they think could be facilitators and barriers of return to everyday life, and how does it impact? The study is published and available on this QI code, and I will only shortly summarize the finding, as it can be very large for a qualitative study like these ones. The first theme was, they say it's transient, no, not for me. And here all participants describe lasting challenges, emphasizing this invalidating fatigue and also an impaired social participation. The second theme was, I'm a changed person, and how does this impact my future? And it reflected an altered identity and an increased alertness to new symptoms. Even small alteration in maybe sensibility or a finger tickling elevated their alarm, and they were living in a constant thought of when and then is the next stroke coming. They also say that time has been my ally and new perspectives on my life have evolved, where almost all participants described an improvement over time. But even though there was improvement, these patients were interviewed 4 months after their diagnosis, and they were still impacted. Also, a few considered the diagnosis as a necessary wake-up call to change lifestyle and also to prioritize the important things in their life. And then the final study was, the final theme was, what should have helped me? And this includes both a personal level, where we can see that that patient who had trustful and close relationship, that impacted positively. When they got acknowledged and supported by their relations, then they managed better. And the other level is the system level. And here we could see that it failed. For the patients who were in need of this acknowledgement and support from the system, we were not able to provide it. Patients described an pressure to return to work, even though their work might not express it, they knew it was there. And then also a lack of trust and negative experiences by involving their general practitioner. They say that there's no time to involve them, and that they are reluctant to include it because they have heard that this was a transient event. So maybe I'm just the one that's the problem and not this diagnosis. And then what is the next step? We know now that for some, it impacts the need for sick leave benefits and also for home care. And we know that more than half express this pathological fatigue, and it at the same level as stroke patients who are provided rehabilitation and support, which these TIA patients are not. And we also know that this level of fatigue maintains up to 12 months after. And we know that we need to ask them about their fatigue levels to identify the ones who are in need of support. It is not enough to only look at key characteristics as sex, age, and acute ischemic lesion. So how do we help them, and how do we support the return to everyday life? And that's what we are doing at this point now. We have had 3 workshops with the healthcare professionals and patients and relatives, where they try to identify what care pathways they think would have helped them in their return to everyday life. And then we are cooperating with the municipality to try to see what kind of an intervention we should test in the future. And this is, of course, not owned by me. It's a whole team of supervisors and statisticians who have helped doing all the work. And without them, there were no project and no results. And thank you for your time.
Thank you very much, Birgitte. Excellent explanation. I think I understood most of it, and that's